Hello and welcome to this special podcast on diabetes. Today, many Indians suffer from diabetes, so much so that it's become the capital of diabetes in the world. What is this diabetes? Why is it important for us to know about it? How do we manage this? We have a plethora of questions to be answered. To answer all these queries today, we have with us a senior diabetologist and a physician, Dr. Mohan, to answer all our queries. Doctor, welcome to the show.
Thank you.
First of all, I'd like to begin our podcast today by asking you the question that why is there such a huge increase in the number of cases in diabetes? So much so that India has become the capital of diabetes today.
We were number 2 actually in the world map, but now slowly we are crossing China to become the number 1, basically because the South Asian population, whether it is both China and India put together, we have a large, almost we cover more than 25-30% of the diabetic population. That's because we have a different phenotype where we have central obesity as the major presentation. So our BMI is low, but our fat in the abdomen is very high. So this causes a change in our pattern of insulin resistance. So we have a very severe insulin resistance. We have a different pattern of lipid profile where our LDL and triglycerides are very high compared to the rest of the world. So this phenotype is a genetic modulation because overall we have a different pattern of food and also a different type of food consumption for many millions of years. So this puts into a different category altogether. So we have a higher incidence of diabetes.
Okay. Today, diabetes is such a common thing that everybody, almost every house, one person is definitely a diabetic. So what are the symptoms of diabetes? How do we know that we've got diabetes?
Correct.
Because as per some studies, they say most of them are even unaware of the fact that they have diabetes.
The problem we face with the diabetes is because of the same reason, because many other illnesses, any illnesses for that matter, patients do have some symptoms which makes them come to a doctor and take some treatment or advice. But diabetes is a silent illness where the symptoms are very mild. Half of our diabetic patients may not have symptoms, and those patients who do have symptoms have a severe proportionate degree of diabetes. Only then they come with symptoms. So these symptoms are very mild. So the most important thing to understand is that diabetes can present without symptoms. So high level of suspicion is very important. So we have some index illnesses where if a person has these kind of infections, they are likely to be diabetic. For example, in infection around the nail, infections in the nose, infections in the skin like boils, or repeated urinary infections. So these are index illnesses. The moment you see in categories of patients whom we do not expect them to see, we have to have a high suspicion of diabetes. The second category is those patients who do present with symptoms. So many of these patients have the most important symptom they present with is with weight loss. And even in these patients who do lose weight, they may not come suspecting diabetes because many of these patients are already overweight and they would have started some protocol for a weight loss. So they may feel that the weight loss what they are having is because of their attempt. So the chances are that they may miss the symptom. The other thing is that they may have an increased appetite. So increased thirst to drink water. So again, this is possible only when their blood sugars are very high. So patients whose sugars are in the range of 200 to 300 may not likely to have these symptoms. So only when the sugars are more than 400, severe symptoms are only those patients who have severe insulin deficiencies. So whether it could be extreme tiredness, fatigue, severe weight loss, muscle loss, they all come in patients who have a severe degree of insulin deficiency. So we need to have a high suspicion. So many of these patients do come for a checkup because they are already aware that many of their family members are diabetic. So what we recommend is that if their parents are diabetic, these people should start checking themselves at any age possible and keep monitoring their sugars every year. And siblings, if any of their brothers, sisters become diabetic, they need to immediately start checking their sugars as well and continue to monitor themselves, because it is generally observed that more or less at the same age as their brothers or sisters, these people also tend to become diabetic.
Okay, doctor. Now there are two types of diabetics. As we know, type 1
Type
and
1
type
and type
2.
2 diabetes.
Type 2 is generally they say it's lifestyle related, and type 1 is it genetic?
Type 1 is not genetic.
Okay.
Type 2 is genetic.
Okay.
Type 1, the cause of type 1 is usually an autoimmune related disease. So these people are born normally. For some reason, there is an antibody production against their own pancreas by their own body. It could be triggered by some simple viral infections, or it could be an autoimmune disease itself, where their autoimmune antibodies will go and damage the pancreas. So the proportionate of damage to the pancreas is very high. So in a matter of period of time of days to weeks to sometimes very months, the pancreas is totally damaged, and their insulin deficiency is more profound. So because of this profound deficiency of insulin, the presentation is more acute. Most of these patients are small, maybe 6 to 8 years old, sometimes 10 years or 11 years old. These patients come with an acute illness. They're very sick, and most of these patients needs to be hospitalized to the ICU. They don't walk in. So again, this presentation is because of the profound deficiency of insulin, because normally severe deficiency of insulin is unviable for a person to live. Whereas in type 2 diabetes, the deficiency of, there are two components in a type 2 diabetic patient. One part is insulin deficiency, and the other part is insulin resistance. So the insulin deficiency is when the patients before 5 years or 6 years before they actually become diabetic, these people develop insulin resistance. So the requirement of insulin goes up, and because of that, in the first initial phase where they actually become diabetic, that is what we call pre-diabetic phase, these patients are managing their sugars by producing more insulin. So these are the patients slowly over a period of time, because of the increased production, their pancreas fails, the beta cell failure, slowly their insulin deficiency starts, and then they become diabetic. So there the loss of insulin production is a very gradual process. And also these patients, beyond the insulin deficiency, they have a severe degree of insulin resistance. So there is insulin which keeps them alive and kicking without any complications, but there is a profound insulin resistance. So the existing insulin fails to control their sugars. So these are the components in type 2 diabetes. So their presentation is less profound. So unless they are very cautious and they watch their symptoms, their presentation is very late. Again, in those patients who come with symptoms in type 2 diabetics, those are the patients who have a severe degree of insulin deficiency, and or patients who come with complications. So they have some infection, suddenly because of the medical or surgical stress, their sugar goes up and they develop a complication like ketosis. So these patients are the ones who come with in emergency, but otherwise majority of the patients, 95 to 96% of the patients in type 2 diabetes, they walk in with symptoms, get themselves treated, and they walk out. So there's only a small proportion of patients who require hospitalization.
Okay. But is there anything specific that triggers type 1 diabetes? And since you said it's generally the smaller kids who are affected, is there something specifically which triggers it?
Generally what happens is that these patients, when they are younger, their immune system is less developed. So there are some triggers, some viral infections which trigger an immune response, and for what we call this molecular mimicry. So these viruses look like the beta cells. So even after the viruses go away, the body feels that the pancreas is also a foreign organ or a foreign virus. So it will try to continue to damage these beta cells, and they become diabetic. So there is no genetic predisposition. So any person can become type 1 diabetic without anybody in the family being diabetic.
So there is no way to avoid it.
No, it's an absolute pure bad luck. Otherwise, I don't think if there's any reason. And what kind of a person becomes diabetic type 1, nobody knows, and it's just a random presentation. And in India it is very less. It's in Western countries the incidence is little more than what we find in India, because I think more Indian kids are more stubborn and more hard to crack. So these people, I think, will have less incidence of type 1. So majority of our patients are type 2 diabetics.
Okay. Now, since I have the symptoms of diabetics, and what are the kinds of tests that we should actually undergo, doctor?
Again, see, normally many a times we undergo random blood sugars, but random blood sugars, we call them diabetic only if random blood sugar is more than 200. But we may miss certain patients, because random sugar again depends upon the type of food they consume, the quantity, and how long since was the last meal. So the recommended method to confirm is to do fasting and prandial sugars. Generally, fasting should be less than 110. So anybody whose fasting is more than 125 is more or less definitely diabetic. So people whose fasting is between 110 and 125, we need to confirm whether they are pre-diabetic or diabetic. And same thing with postprandial sugars, that is sugars which is done 1.5 hours to 2 hours after food. They should be generally below 140, but up to 140 to 160 we may miss. So they need to do a repeat test and follow them up. And again, HbA1c is something which is not dependent on their day-to-day meal. So HbA1c is a more important test to do the diagnosis. If HbA1c is less than 5.7, it is non-diabetic. Between 5.7 to 6.5 is pre-diabetes. And anybody with even a single reading more than 6.5, we label them as diabetic. So subsequently, even if they're with a diet, if their HbA1c falls below 6.5, we continue to call them diabetic, but whether they require medications or not, it's a different thing. But one single reading of 6.5, anytime during the lifetime, we take them as diabetic.
Now, if we have to go for a test tomorrow, what is the gap between the food, the last meal and the test?
Generally recommended is about 8 to 12 hours fasting. But again, as I said, the fasting sugars and prandial sugars themselves may miss certain category of patients. So always we do the HbA1c to pick those patients who are missed by the regular methods. But HbA1c again is independent of the meal pattern, independent of the type of food they consume. So it can be done any time of the day, especially those patients who walk in with for a random sugars. HbA1c is more reliable because it's very likely that they may pick them up as diabetic rather than thing. But at the same time, what we need to keep in mind is that HbA1c is an average. So there may be a category of patients whose fasting is very low, prandial is very high, or fasting is very high and prandial is low or normal. So the average may still present to be normal. So these are the patients whom we need to keep monitoring, because entirely is a different set of patients, because some patients are what we call IGT, or impaired glucose tolerance. So these patients fasting sugars will be high, but their HbA1c is normal. So these patients we need to follow them up. Over a period of time they may become diabetic. So these are the patients who are the target for us, because these are the patients whom we can prevent them becoming diabetic.
So now when we get the test done, doctor, what is considered as a safe zone and what is considered as a danger zone? Fasting
sugars anything less than 90 is definitely normal. From 90 to 110 is a gray area. We need to keep taking it as early diabetes, or we need to monitor them. But anything more than 110 fasting is taken as diabetic, but anything more than 125 is definitely diabetic. And prandial again less than 120 is ideal, especially patients who are pregnant or planning for a pregnancy. Less than 120 is the ideal target. But certain patients we may relax up to 140, but anything more than 160 we definitely take it as diabetic. And again same with the HbA1c, 5.7 to 6.5 is pre-diabetes, but anybody with more than 6.5 we need to take them as diabetic.
Now is this the same for all age groups?
It is same for everybody irrespective of the age. Only the targets are different. So when patient is finally diagnosed as diabetic, when we treat, again the target changes, because to diagnose diabetes is different. But when we start diabetic management, the targets are different. So when we begin with our initial target is to bring the HbA1c below 7. That's the ideal thing, because many a time our complications will be less if the HbA1c falls below 7. But patients who are young and who are likely to live for 50 years with diabetes, we need to be more strict. So younger patients we keep a target of 6.5. That again depends on the lifestyle. So while trying to bring it below 6.5, we should not have them to undergo hypoglycemias. So if I can achieve HbA1c of 6.5 or less without causing hypoglycemia is a very fairly good target. But in an elderly patients who already have because of their age, we are less stringent. We relax the targets. Sometimes up to 7 is fine. And especially very old patients, we don't even have a target. So just keep them healthy without any complications. So anything more than 7 is acceptable as long as they do not fall sick or there is no complication related to diabetics.
And now, doctor, there's a talk that, like the readings have been altered. Like, earlier the readings were high and now they've brought it down. And the whole intention is to bring everybody under diabetes, under the umbrella, so that everybody becomes a diabetic. Now, is this true or false?
It's not correct. See, our understanding of diabetes, for that matter, understanding of all the illnesses is a dynamic thing. So, what is good today may not be good for tomorrow. So, we always go with these trials. So, the best trials what we was done is called NADDM trial, which was done in Europe and in India, and these were the targets which were kept, because initially the assessment was that beyond this, see, when I see a patient who is non-diabetic, normally if he is not at all diabetic, fasting sugars will be 50, prandial sugars will be 70. So for a diabetic patient this is too low, but in a normal patient, that is the sugars what we see in a normal person. So when I say a patient is diabetic, I am already giving 40 margin and making it a diabetic only beyond 90. And prandial, imagine in a normal person it is 70, but I call him diabetic only when it crosses 140. This is because majority of these patients, even though it is more than the usual values, these patients, all of them do not develop complications. So there is a general consensus that beyond certain cutoffs, the complication risk is more. So over a period of time, these assessments keep changing, and based on the assessments, our target will also change. So this is one. Now we are more stringent because younger patients are becoming more diabetic. So we need to have a more different target than the older patients, because at that time lifestyle was different, our understanding was different, and even in the older times our medications were different. So we were unable to bring it beyond certain levels without causing hypoglycemia. So now we have medications which we can be brought the under 6.5 without even a single episode of hypoglycemia. So our availability of choice of treatment is becoming better. So obviously our targets are also becoming more stringent.
Now, as you mentioned, younger children are being more exposed to pre-diabetes. The percentage is definitely increased over the years. What do you think is the reason, doctor?
It's basically because I think more healthy children are born. So, and our assessment of diabetes, our testing protocol is now very stringent, and people who are born fat generally have a tendency to become fatter during their later growth, and the chances of them becoming diabetic, especially if their parents are diabetic, becomes more. So being born with obesity is itself a risk factor. Second thing is that there are patients who are born normally, but over a period of time their lifestyle or their feeding habits or their parents feeding their children the way they feed make them obese. So the rapid sudden weight gain or rapid gain in weight may also predispose them to become diabetic. So again the food style. More children are more exposed to, present generation is more exposed to food which is easily consumed and more easy to digest, compared to the older generation where it used to be an unrefined kind of a diet, whereas the present generation tends to have a more refined, easy to digest kind of a food. So what we call junk food. So but when you look at the pattern of meals, I think over a period of time the pre-digested meal makes it more riskier for patients to become diabetic.
So in your case study, doctor, are the girls or women being more vulnerable, or the boys or the men?
I think it's more equally placed, but if you look at the genetics, more men tend to become diabetic than women, but more women tend to be diagnosed early because of their requirement of pregnancies and other things. So normally it is a pattern that once a patient comes with pregnancy, the first thing they check is their sugars. So they are more likely to be screened than men. So because the men, it is usually with the symptoms that they undergo for a certain test. So they're more likely, the girls and women are diagnosed early rather than the men. But the incidence is more or less equal. And again, because of the other requirements of medication in girls and women whose cycles are irregular, so there may be a tendency for them to be on hormones and other things. So these things predispose them to become diabetic or their sugars to become higher. So that is a reason why we see that we notice that more girls and women tend to have more sugars rather than men and boys.
Okay. So once they are diagnosed with diabetes, doctor, there's a lot of confusion about what to eat, what not to eat, and how to manage and all that. What is your advice to them?
What we need to understand is diabetic is not a disease, it's a lifestyle illness where it came because of certain things which was beyond your control, but what you consume is fully under your control. So being diabetic is not a curse. What they need to think is that free lifestyle should change into a more stringent and more methodical lifestyle. So that's the only difference. They can continue to consume what others are taking, but in a more organized way. So what they need to understand is that the diet is an important component in managing the patient's diabetes. So they need to become more methodical. So the timely consumption of food equally important than what they consume, how much they consume. So they need to understand two important things in their diet. One is the glycemic index, the other one is glycemic load. So both are equally important, because there are foods which have a very high glycemic index, means these are the foods which increase the blood sugars rapidly, but they are consumed in a lesser quantity. So even though they are increase the sugars rapidly, the overall blood sugar impact is very less, because we consume them less. But at the same time, there are foods which have a very low glycemic index, but we consume in a larger quantity. So the glycemic load, or the entire amount of carbohydrates or energy which enters the blood is very high. So whenever we consume food, so we need to moderate the type of food and the amount of food based on what the impact will be on the blood sugar. So those foods which have a higher glycemic index, but when consumed in lower quantity has no effect. Whereas those food which have a lower glycemic index, but when we consume more, will have an impact. So the foods which are more refined, like rice for example, will impact the blood sugars, because we have removed the fiber, we have removed the husk, we have polished the outer fiber thing, and it's more refined. So this will have a more glycemic index, although it is similar to the other cereals. The amount of glycemic load, because we consume them in cooked form, and the foods we prepare, whether it is cooked rice, idli, dosas and other things, are in a more easier way to digest. So these will put them into a category where consumption of these things will increase the sugars more rapidly. At the same time, the unrefined cereals like ragi, jawar or wheat and other things may have a less impact on the blood sugars, but that does not mean they have less sugars, because the sugar content in all the cereals are more or less the same. For example, the wheat, even though it contains similar calories of 360 to 370 like the rice, it contains double the amount of protein. So rice contains 7 grams protein, whereas wheat contains 14 grams protein. So when you consume these food in the form of chapatis and other things, where it takes more time to digest and more consumption is less compared to the component of rice, the amount of impact on the sugars is much less. Again, the habits of food types like what we consume, ragi and jawar, make them less increase in the sugars, because the pattern we prepare, whether it is rotis and other things, will take more time to eat, more time to digest, and probably they fill your stomach early. And because we all tend to eat these things with a salad, vegetable salads and other things, which fills your stomach. So again, these added fiber makes them less likely to increase the blood sugars. So, and again, certain types of foods will also have some additional things which may themselves cause reduction in absorption of the blood sugars into the bloodstream. So this slowing of intestinal absorption will also have an impact on the blood sugar control.
Once they're diagnosed with diabetes, is indulgence into sweets, because they're already on medication, is indulgence into sweets okay? I mean, some people have this notion saying that, I'll eat sweets today and have an extra pill, or, take an extra dose of insulin. How good is that, doctor?
Binge eating is what we call is not good, because because the regular medications are planned and measured and adjusted based on the blood sugars, whereas the binge eating, we do not know what they consume and how much they consume. And second thing, it is a wrong notion that I can adjust for a binge eating, because today I've eaten more, so how much medicines to give? It's a very difficult thing. So what adds to the problem is the glycemic their blood sugar variability, because these extra meals or extra consumption of calories will only make their blood sugars highly variable. So this increased variability in the long run is going to create complications. So it is always what we say is that whenever you indulge in something, we call it what we call the exchange program. So we have a certain extra calories today, so I am going to eat less with my regular meal and compensate for my sweet consumption. So this is fine, because we allow a certain amount of feasting, but with a dietary control on the regular meal. So what is important is to consume these things in a planned manner. So when you plan things, you are allowed to have everything what the other non-diabetic patients are having, but you need to plan your meal rather than do a binge eating and getting your sugars into complications. And again, whenever you take these medicines in an unplanned way, the risk of hypoglycemia becomes very high, because we do not know, we could not match the medicines with the amount of sugars for which the increase is happening.
Doctor, they say diabetes shortens your lifespan. Is there a way to manage diabetes and increase your lifespan too?
It is not true that diabetics don't live longer, because it is basically because the patients with diabetes can have some extra illnesses which make them prone and lead to complications and also reduce lifespan. So as long as these patients manage their blood sugars in a proper way, they are as good as anybody else. So the patients with diabetes whose blood sugars are well controlled can live as normally as a patient who is not diabetic. But what they need to understand is that very good sugar control and a very good lifestyle makes them have a good and a longer lifespan. And these patients, they need to realize that they have a slightly an increased risk of illnesses which are not presenting with symptoms like cardiac illnesses. So they need to be more aware or consciously monitor their the complications which are coming, and they need to treat accordingly. Based on that, their lifespan may be as good as any non-diabetic person.
So like, what should be the frequency of tests, doctor? Like, is it like only in the laboratory tests, or can we get it tested at home with the glucometers?
Generally, we don't have a fixed pattern of blood sugar monitoring. The more frequent, the better. But depending on the individual patient's profile, we need to plan how frequently they need to state. Patients who are pregnant or likely to become pregnant, they need to have a good sugar control. Patients who are likely to undergo a planned procedure, they need to have a good sugar control. Patients who are not well have to have a better sugar control than patients who are in a normal day-to-day life. So the frequency of testing depends upon the need. So and again, we also need to look at the monetary aspect of these testing. So we need to have a moderate decision on how frequently test based on the patient's condition. So there is no fixed pattern. Of course, the difficulty in doing a laboratory testing, unlike the self-monitoring of blood sugars or SMBG, is that because we need to go to the laboratory more frequently if I need to monitor more number of times, which is difficult. And second thing, many laboratories may not be working late in the night, so certain time of testing may not be possible. So whereas the SMBG, because it's very convenient, it can be monitored at home, and because you can do it more frequently, because it's very easy to do it with only the fingertips, so it's more easy to monitor. And again, many of these patients who are on medications, we also teach them, if they are on insulin especially, we would have taught them how to adjust their insulin dose based on their blood sugars. So monitoring self with their own glucometer makes sense, because we can always tell them how to do minor adjustments in their medications, especially the insulin, when they are doing their blood sugars themselves.
Okay. And nowadays people are more going in for the CGM bands, doctor. Is it safe, and how reliable are they?
CGM gives us a minute to minute or a few, there's a fixed pattern where sugars are monitored at every fixed interval, and it gives a overall pattern of 24 hours. So sometimes 21 days readings is what we given. But the problem with CGM is very expensive. So for a normal person to undergo CGM is not recommended, because when you do self-monitoring with more number of times, is more informative and at a lesser cost than compared to CGM. But what we recommend for CGM is for patients whose blood sugars are very variable. So pregnancies, patients with type 1 diabetes, because these are the patients who are entirely dependent on their blood sugars by the external insulin. So these patients' blood sugars are very variable. So these are the patients whom we need to monitor them more strictly. So this is one category of patients we need to do CGM. Those are the another set of patients are those people who come with repeated hypoglycemias. So they have symptoms of low sugars, but we are unable to pick up the hypoglycemia, because by the time they come to us, the sugars are already normal. But the symptoms do match that these people are having hypoglycemias at some unknown times. So these are the patients whom we recommend CGM, But again, this is not a regular thing, so we cannot keep doing it again and again because it's a costly affair. Because again, when you do this CGM repeatedly, the treatment and diagnosis of diabetes will become more expensive, and many patients may start feeling that they have got an illness which for which they are spending too much of their earnings.
So basically CGM people with high blood sugar, they do not have to use CGM.
Correct, because anyway our aim is only to monitor blood sugars. So if they already have high sugars, we need to control the sugars rather than keep checking and finding out how high the blood sugars are. So we are worried about hypoglycemia. So the people who have more risk of hypoglycemia are the ones which require CGM.